That relates, it's funny about diabetic ketoacidosis, but it's not diabetes. Very important thing, especially if you're living in the United States. This is more of a first world problem. So I didn't see nearly as much diabetic ketoacidosis as I see working down here at Fort Sam in San Antonio, unfortunately. A lot of that. And what's the thing that this runs with, potentially? Everybody knows HHS, hyperosmolar hyperglycemic state, very similar to diabetic ketoacidosis, can be just as life-threatening, but we're not going to get into HHS. Here's your reference material. Here are your objectives. Definitely need to be able to define that. And get a little bit into the pathophysiology because you really need to understand that to make sure that you're not going to do more damage to somebody that comes in diabetic ketoacidosis. And how does that person normally show up? They come in and their glucometer at home says too numerous to count or too high. It's not even giving you a number. So that's not good. That's not good. Most of those glucometers at home go up to about 800. I've seen people up to upwards of 1,1500 in diabetic ketoacidosis. So start off with some pearls here. Keep in mind this is substantial dehydration. I would say with diabetic ketoacidosis, these people are at least 5 to 6 liters down. 5 to 6 liters down. And how much is a liter? About the same as a quart, about 32 ounces. About 32 ounces. That's a lot of liquid. So, and then we get these life-threatening electrolyte shifts. Specifically, when we're talking about potassium, is probably our biggest one to be concerned about. So, just keep in mind they are total down in potassium, even though their blood levels may come back normal. So all that is third spacing. It's going into areas. It's not in vessels, going into the body in these third spaces, and that causes some pretty significant issues. We don't want to intubate these people. We want to prefer not to intubate them. Why? What do people with diabetic ketoacidosis usually come in? They're going to be breathing very fast. Tachypnic, which is also known as Kussmaul breathing. They usually for deodor, but not every time. I say every time. We don't want to intubate them because what are they trying to do by being tachypnic?
Compensate.
They're acidotic, so they're trying to blow off all those hydrogen atoms as quickly as they possibly can. That's why they're breathing fast. So they're in a metabolic acidosis. That's what we're going to do. So if we tube them and put them on a ventilator, we're not letting them blow off all that acid. They're going to get more acidotic. It's not good. So presenting complaints sometimes, they can be non-specific. They might say, I'm lightheaded, I'm dizzy, I syncopized, I passed out, whatever. So just beware. Checking that glucose should be considered in people that are giving you kind of some ambiguous types of complaints. I feel dizzy, I just feel weak. Check the glucose on those folks. You want to take that off the plate right off the bat. So keep in mind the most common triggers. We'll talk about the 7 I's that cause diabetic ketoacidosis. But number one thing you should be concerned about, number one thing you should jump to is where does this person have an infection at? An infection is going to cause them to go to decay. And then what we worry about with kiddos, this is a pediatric concern, they get significant cerebral edema. They cannot handle that. Very rare in adults with decay, but very common in kiddos. It can be very life-threatening. So how does that break down? Predominantly in type 1 diabetics. These are people, now they can get adult onset, not very likely, they're normally born with this, and it requires insulin, versus you have 10 to 30% current newly diagnosed type 2 diabetics. I told you guys, got a Fort Bliss, my first duty station, I diagnosed a third of the medical platoon sergeants in my grade, or in my brigade, with diabetes. 1 adult onset, 1 late. So I ended up taking my platoon sergeant with me to Afghanistan, got his hemoglobin A1C under 7, and didn't check it again until I got him to Afghanistan. Just made sure, but he just required metformin, stuck with the lifestyle changes, was completely fine. Completely fine, just be aware of that. So, but all those guys presented very common. It wasn't I had like a serious light bulb going off. They came in with weight changes, polyuria and polydipsia all day long. I just had to get a fasting blood glucose to make the diagnosis. Not super difficult, but caught it early with them. So, how's the pathophys? Cellular starvation brought on by insulin deficiency. Where does insulin come from? Pancreas. So just think about that. When the pancreas is not working, our patients are probably going to get hyperglycemic because it's not producing the insulin that it needs to. It's not creating those counter-regulatory catabolic hormone excess. So we have glucagon, catecholamines, cortisol, and growth hormone. This causes excess production and underutilization of glucose because of the excess production and underutilization of glucose. So, and then we have all these other downstream effects, what we call second-order effects. So you have that problem. It's going to result in hyperglycemia just overall in the body. Because of that, it's osmotic diuresis, which is why, because things move from higher concentrations to lower concentrations. That's osmosis. I wish it worked with you being able to study and books would just flow into your head. It doesn't work that way. So pre-renal azotemia, ketone formation because of the breakdown that's happening in the body. And then we have that metabolic acidosis, which produces usually that Kussmaul breathing along with the acidosis that's going on in the blood. Acidosis. Now, here is important causes. I'm not expected to know all that stuff. Okay? There's a much easier mnemonic, and I'm sorry I misspoke earlier, it is the 8 eyes. The 8 eyes. And just think of all these eyes. These are all the potential causes. Somebody comes in DK. What is going on? Number one thing is that infection. So it runs with pancreatitis, pneumonia, UTIs. We need to think infarction. Now that can be an MI. With infraction, we think about a patient that's not being compliant with their medication or their therapy. Infant, so pregnant women obviously can get gestational diabetes, given the DK. Then we have ischemic, and we need to think about CVA. So a stroke in the brain or a heart attack can be the cause of diabetic ketoacidosis. I had a gentleman when I was at Madigan bring his wife in, a surgeon, and said, hey, her blood sugars have been off the chart. Keep in mind this is around Christmas time. And asked her, she said, I've been eating whatever I want. I'm not really worried about it. And I look at her surgeon husband, I say, what do you want? He goes, you know what I want. I want the full workup. He goes, you're going to get, I said, yes, I'm going to get a troponin. He just wanted to make sure it wasn't a silent infarction that was going on that was putting his wife in the DKA. He's smart enough to know that one of the eyes was on there. So that's why I say you got to know your audience. I was pretty sure that she was just in the infraction portion, just not being compliant with her therapy. Anyway, illegal, iatrogenic, so that can be caused by medication. Steroids is probably your number one offending agent that's going to cause a increase in blood sugar. What does steroids also cause? A leukocytosis. And then you have idiopathic, and that just means we haven't figured out what's going on with that patient yet. So always be on the steroids, beware of those steroids, be very careful with that. How those present, like every single one of those medical platoon sergeants, polydipsia. So feel like they're unquenchable thirst. Unquenchable thirst. They're like drinking all the time. And that's just their body trying to rid itself of the sugar. They're polyuric because they're peeing all the time. And then we start getting a ketonemia and an acidosis develops. So increased ventilation, why they're trying to blow up that CO2, trying to blow up those hydrogen atoms that are creating acidosis. And then there's a release of prostaglandin that they believe causes the nausea, vomiting, as well as abdominal pain. Keep in mind, if they are having nausea, vomiting, that's going to increase the potassium loss. That's not going to help things out. That's going backwards. That's going backwards. And then mental status may be affected as well. But that has a lot to do, that's more related to the hyperosmolality. I have another slide that shows that. So please don't tell me it's how high that their blood sugar gets. It is not. It is the osmolality that determines how much altered mental status that patient has. Right there. So above 320, that's when we get concerned. Now we're getting into also potentially a contaminant DKA and HHS picture. So that is the problem. That is more important. That alteration of consciousness correlates with osmolality going up much more than how bad the metabolic acidosis is for the elevated glucose. For the elevated glucose. So that Kussmaul breathing, please, if you want to look that up, you can YouTube that and see what that looks like. Not everybody is going to have that. Be aware of this increase in depth of breathing. So sometimes fruity odor on the breath from the acetone. Just be aware of that If they do not have fever, does not mean that they do not have an underlying infection. We'll be catching this very early. A lot of times, because they have that peripheral vasodilation, they're going to be hypothermic and not febrile. They're going to be hypothermic and not febrile because of the peripheral vasodilation. So, abdominal pain tenderness can correlate to the level of the acidosis, and then just be aware pain can also be due to this. So you're going to have some gastro-dilatation. Can also have an ileus forming, where everything just kind of comes to a stop, anal pancreatitis. So just be aware there can be other types of things. Surgical abdomen could be happening at the same time. How do we specifically diagnose it? We need to know these numbers. So blood glucose above 250. Most of those people are going to be in the realm of 700, 800, but above 250, anion gap is present. Now, a lot of places will make you calculate that, but it actually comes right out on labs. Bicarb levels low. Bicarb levels low, and pH is obviously low, 7.3, making them acidotic. And then we're going to have a ketonuria, which is in the urine, but we can also have a ketonemia, where sometimes if we don't see it in the urine, we need to order a blood test for ketones, and we'll see it there. So, your differential, what other types of things? There are a few toxidromes, if you will, but we can also have these other things: alcoholic ketoacidosis, starvation ketoacidosis. So somebody that's been on a bender can put themselves into alcoholic ketoacidosis, which is very similar. Renal failure, lactic acidosis, and we worried about these toxidromes as far as ingestions. This would be a PANS question. What type of toxidrome are you going to see tachypnea in? I'm going to tell you right now, all day long, that's going to be salicylates. So aspirin, or somebody just decided they're going to down like 3 bottles of Pepto-Bismol, because that has salicylate in it as well. You should be aware of that. What are we going to do to work that up? So let's get a glucose stick. Hopefully, if they came by EMS and they're in a rig, they got a stick already with a better glucometer. But we have to get that VBG. VBG is going to give us an idea of that acidosis. ABGs are kind of how they used to go. Now we do BBGs, and everybody can do BBGs. What's the difference between an ABG and a BBG based on you're obviously drawing from a vein versus an artery? What do you think you're going to see on BBG? Probably a little bit more CO2 and a little less oxygen because it's already been taken from the body and heading back to the heart to get replenished. Okay, that's about it. As far as the pHs and everything, we don't need to worry about trying to get that ABG. By the way, ABGs are pretty tough to do. Here's a person in your hospital that can get you an ABG, probably the best. RT. Respiratory therapist, that's what they do nonstop. After they place that ventilator, they are drawing an ABG to figure out exactly what they need to do with tweaking all those buttons to make sure that everything's right. So, complete metabolic panel, why we need to look at all those electrolytes, complete blood count. Not really worried about so much if they're hypovolemic or if they're anemic. I'm worried more about is there a white count. If there's a white count, it's going to lead me to an idea that I need to be looking a little bit more for an underlying infection. Calculate that anion gap. I'm not going to have you do that for a test. ABG if that patient is significant or if they ever had to be placed on a ventilator, they may give them ABG up in the ICU. Pretty much don't do ABGs down in the ICU department. Other testing, potentially get ketones, but we really need to look at that potassium. So it's being depleted because of the extracellular shift and potentially for loss. It's happening within the body. It's going to be very important that we get an EKG on these folks right off the bat. We get an EKG right off the bat because we need to see is there evidence of hyperkalemia or hypokalemia, but especially if we're worried about ischemia or infarction from the heart. We need to see if there's ST elevation or any ST changes indicative that we're having some type of ischemic or infarction that's happening, especially in our older folks that come in DKA. That can purely be in DKA because they're having a heart attack, so we'll get that EKG. How do we want to start treating these people? Once we've tested them, figured out what's going on, obviously ABC's in place. If they're cruise small breathing, it'd probably benefit to put them on some oxygen, make sure that the breathing circulation is intact. Volume first and foremost. That person needed an IV probably as soon as they walked into the emergency department. They are volume down. 5 to 6 liters, I told you, for DKA, HHS, anywhere from 9 to 10 liters down. That's a lot of fluid. We need to get that fluid going right away because we need to replenish it because they're so deficient but also, what are we going to do when we dilute out all that sugar? We're going to be dropping their sugar naturally before we get other things in place. And then we have to correct that potassium, the K, before we start any insulin. You have to do it in that order. We don't start insulin right off the bat. We don't do that. So we need to give IV fluids. Initial fluid bolus at 20 milliliters per kilogram. So twice maintenance. So then we look at potassium. I got some more slides that kind of break this down for you visual folks. But 3.3 to 5.3. We're going to add potassium at 20 milliequivalents for each liter of maintenance. And then once we get that glucose to drop below 250, we're going to put in D5W. We're going to put in D5W. So insulin infusion, we have to be at least 3.3 with regular insulin at 0.1 units. So then we're going to continue until we get our goal of our serum bicarb above 18, our pH above 7.3, and then anion gap is closed. So chances are you're not going to be getting that in the emergency department. You're not going to hang on to that patient long enough. They get DK, you're going to start them with fluids. Sometimes I'll start them on insulin infusion. Most of the time, I will talk to the inpatient team. Why? Because I give somebody an insulin infusion. I just bought them a bed in the ICU. No regular floor is going to take a patient on insulin infusion. What they prefer, can you give them 10 units sub-Q? I'm like, whatever you want. You're taking the patient, I don't care. So 10 units and then just continue to monitor. We talk about monitoring. But just realize if I start that IV infusion of insulin, now if they're bad enough, I'm not worried about that. But that pin holes in that patient has to go to the ICU to be monitored. It has to go. So, and then we can potentially give sodium bicarb, but that's only if that patient has severe hyperkalemia, the hyper K. That's really way above 5.5. I'd say probably in the realm of 6.5. I would get concerned about that, and that's when you give bicarb. Otherwise, we're going to put them into a lethal arrhythmia from hyperkalemia. Oh, fine. So, look at that. We want, ideally, if we know that they're in DK and it comes to the roof, we need to be giving them fluids right off the bat before even those lab results come back. We need to replace the volume. Replace that volume. That reverses all your metabolic consequences from insulin insufficiency. It's also going to help correct that electrolyte and acid-base imbalance because it's going to bring that sugar back down, so it's not going to be so hypertonic. It's not going to be so hypertonic. And then it also helps us to start identifying those causes and then avoidance of complications. So fluids is what we reach for first before we start jumping down the I need to replete potassium or I need to start this patient on insulin. Now if we figure out that's an infection, I mean we're going to throw some antibiotics in there as well. So if that patient's in there, we're hanging onto them in the emergency department. So we're going to monitor the glucose every hour. I'm going to tell you, you're going to get a drop of about maybe 40 to 50 in the glucose per hour. So it's kind of a slow process, but we've got one slow roll. As long as we're moving down, we get the patient better, and then monitor electrolytes every 2 hours. And if we're hanging on to that patient long enough, we want to get the glucose below 200. Bicarb needs to be above 18, and the venous pH above 7.3, so no longer acidotic. And they have enough bicarb to compensate for that acidosis. And that glucose is low enough now that it's not so hypertonic that it's third spacing on the potassium. Everybody understands what I mean by third spacing. It's just osmosis. It's going to push it from the bloodstream into all the tissues that are in the body. Okay? Rapid fluid replacement, so initial rehydration, isotonic saline, and then subsequent potassium replacements. And low dose insulin provided the potassium is good. So most patients we're not going to have to reach for bicarb. Again, that's your hyperkalemia. I'm not talking about just barely above 5.5. I'm talking like 6, 7. That's going to go into lethal arrhythmias. Have you seen hyper K? Start getting peak T waves, and that QRS starts going out, and you run the risk of torsades or defib. No fun then. And then again, cerebral edema in children, adolescents, not a big concern with adults. So usually they do have pretty profound, so most of the time you are going to have to give that. So we worry about that. Hypokalemia can cause fatal arrhythmias, paralysis, ileus as well as rhabdo. Those are the four main concerns with that. So we want to make sure that they're not hyperkalemic. We want to give that starting at 20 milliequivalents. Here's a nice slide for you right there. So if we're in the regular range, we're going to be giving K. If we're above 5.2, no K. Above 5.2, no potassium. Regular range, potassium, below potassium. Just a matter of how much. I can expect you to remember any numbers there, but that's usually 20 milliequivalents. If they're within the normal range, if they're above 43.3, you're probably going to bump to 40 milliequivalents. And then double that. So what do we do with these folks? Disposition. Again, if they're unstable, altered, they're going to ICU. If we can get that anion gap low enough, get the glucose under 600, no comorbidities, and they said, hey, just give them 10 units and keep fluids going and send them upstairs. You're going to find anything else that we're concerned about, we'll take care of them, no comorbidities. We'll take them on the general ward. So there's potential if we get on this super early and the patient can handle PO. We've got everything figured out. We know that there's not any underlying cause. There's potential that we can discharge that patient. There's potential. And this is just a slide on diabetic ketoacidosis. I'm not testing you on that. This is right next to the Krebs cycle and it needs to stay in the black box. I told you these are going to be a lot faster. I don't know about funner. I don't even think that's a word, but whatever. Questions on diabetic ketoacidosis? There's one answer on this slide, but I would tell you that there's another potential answer. It's not listed here, but obviously this answer is C, right? I want to make sure we're not missing that silent ischemia. I reserve that mostly for my older female diabetic patients. Those are the ones that are come in that are like, I feel fine, I just feel kind of weak, I feel a little dizzy, and my sugars have been out of control, and you get their EKG back. You're like, oh crap. But we also want to look at that just to make sure that we're not getting in that realm of hyper or hypokalemia. I think that would be another close answer. We're not reaching for bicarb. Rarely reach for bicarb unless they're hyper K, and that person's got a K of 3.5, so I'm not concerned about that. Sodium's not going to do squat. So, and I told you we have to fix the fluid first before we mess with the potassium. So, see ya. Now this one gets a lot of people. It's a lot of people in phase 2. You know why? Because just read what is it? We're talking about diabetic ketoacidosis. So diabetic, obviously, right for that. They all say hyperglycemia. Well, okay. Let's move to the next one. Diabetic ketosis. Well, there's only one there that lists that, right? And what's an acidosis? An acidosis is a low blood pH. Very simple, it's E. Very simple. Strongest evidence. So I told you not everybody's going to have a fruity breath, not everybody's going to be tachypnic, not everybody's going to be altered, not everybody's going to have fatigue. So give you an idea on that. So, but every person that has DKA has hyperglycemia, ketosis, and low blood pH. Make sense? Are you ready to get into some sepsis? Keep me on 41 slides. I will pay attention to the time, so we should be finishing up 20 minutes with our first block here. What do you guys have this afternoon?
Surgery. Everything.
Surgery and?
Women's health.
All right. Let me get into sepsis. This is a big deal. This is more of an emergency department type of thing. These people get really sick really fast. When you come in, you got to recognize as quickly as possible, or they don't make it. So, just like the video there, they talked about Sears criteria. There's something called Q-SOFA out there that is usually more of an internal medicine type of prognostic medicine decision-making tool. But I think for the emergency department, the Sears criteria is going to be much more important. I would recommend knowing that, especially for the PANTS. Reference again there. I'm going to talk about here's your objectives. Pretty standard with how we do that. We talk about definitions, pathophys, moving on to diagnostic evaluations, ED management. A lot of people think that we're very cavalier because we will reach for antibiotics very quickly in the emergency department. If we even think that someone's septic, it's okay to give them a dose of antibiotics. If I think somebody's like right on the edge, I might give them a dose of IV antibiotics and then send them home with oral antibiotics. The IV antibiotics just to get them moving in the right direction. I feel a lot better about that kind of thing. So start off with a warm-up case right here. The thing we need to do first, right after that, I don't like that blood pressure, and I don't like somebody who's tachycardic, so I'm going to get right on fixing that. I would like to get a temp on this patient. What do you think is potentially going on with this lady? What type of infection is she having? Probably mastitis. Probably to start some IV antibiotics as soon as possible. I'm going to say right now, based on her altered mental status and weakness, probably not somebody that I'm going to sit home that's going to take care of her kiddo. Not saying that her kiddo has to go home separate from her, but IV antibiotics, fluids definitely. And then if we're starting IV antibiotics with any patient we're concerned about sepsis, we're making sure we're getting pan cultures. So I'm going to get a UA, I'm going to get a urine culture, I'm going to get blood cultures from at least 2 different sites. So 2 different arms, or let's say that that patient is on hemodialysis and has a port or has a fistula. Say they're on chemo and they have a port, we probably need to get some sample from that port or that fistula as well. Those are likely sites where infection would show up. So I get worried about those types of things here. I want to check all those different sites. Ideally before you start antibiotics. And then any inclination that this is a meningitis encephalitis picture, we need to be looking at an LP, but again, we don't delay that. So here's your introduction, characterized widespread. That's why they call it a systemic inflammatory response system, because it's widespread inflammation. And we get concerned about because organs, because of that widespread inflammation, start shutting down. When we start dealing with end organ damage, that relates back to sepsis, we're going to put our patient in a very, very bad place. Very bad place. So impairments in oxygen delivery, that's why we monitor that with lactate. That lactate gives us direct idea of how much inflammation is being caused that's affecting the oxygen delivery into the body. So, and then multi-system organ dysfunction starts happening. Sadly, despite all of our medical advances over the years, we still have high rates, so 20% dying during hospitalization. If they get into septic shock, and we'll explain that exactly, that's when the cardiovascular failure starts happening. These people start getting significantly hypotense, and they require vasopressor. If they get into septic shock, we're approaching 50%. That is not good at all. So here's your sepsis, suspected or confirmed infection with evidence of systemic inflation. So we're going to see systemic inflation, probably going to see an elevated lactate. We're getting a septic shock when that cardiovascular failure occurs. So what happens there, lactate's going up, we're going to see persistent hypotension. We need to start that person on vasopressors. Vasopressors. What are your most common vasopressors? Which would probably, we're doing shock. so norepinephrine. So, and we used to be big, that had to go through a central line. Most big hospitals will be putting a central line if somebody needs a septic shock. You can get it into the body, directly into the heart a lot quicker. But a lot of people are more comfortable now with actually giving vasopressors peripherally, the peripheral IV, not a big deal. So, we see with our criteria here. I definitely need you to know that criteria, systemic inflammatory response system criteria. So you can get into sometimes little bits of discussions, borderline arguments with ICU folks and whatnot because they like this Q-SOFA thing. But Sears is really what's going to kind of tip us off. So we have them as a fever above 38.3, hypothermia below 36, so pulse rate above 90, or 2 standard deviations above the normal value for the age, tachypnic above 60, and then leukocytosis above 12 or below 4. So we look at those types of things. So can somebody have that type of a response and not have Sears? Absolutely, absolutely. But keep in mind, we're going to take a good clinical picture. We're going to look at that fever. There's your other general parameters, and then we start looking at other type of infectious parameters. C-reactive protein, give me an idea if there's significant inflammation. And then any ICU will love you if you order a procalcitonin from the emergency department. That gives you an idea that it is a pulmonary or a GI-related infection. They love that procalcitonin. It's like, oh, the smart guy told you that. It's at the bottom of that slide. I'm not going to test you on that, but just know that procalcitonin is another indicator. If maybe that's such an early infection that the leukocytosis hasn't happened yet, we're not seeing other parameters that have hit there, the procalcitonin can let you know that something underlying is happening. And then if I really want you to know more, pay attention to this slide, but I just want you to know as you take those patients in and you're working on a ward, here's the other things that you're going to have to pay attention to as far as organ dysfunction. Obviously, these people aren't producing urine. These people are severely hypoxic. They continue to be hypotensive, letting us know there's a septic shock. And we start having other end organ damage, ileus, thrombocytopenias, hyperbilirubinemia. So all these other types of things that they're going to monitor. If you have severe sepsis, that's all going to be monitored by the inpatient team. ICU is going to have them on labs. They're probably going to be on a ventilator, and they're going to continue to monitor all these types of issues. So here's the other one that I talked about, the Q-SOFA. Q-SOFA tool, so quick sequential organ failure assessment. That is more inpatient to determine morbidity and mortality. So that was developed in conjunction with the sepsis 3. And look at that criteria. I think you're going to miss a lot of sepsis in the ER if all you're doing is based off altered mental status, a respiratory rate, and a systolic blood pressure. That's why I think that Sears is so much important. I need you to know those 4 parameters. So again, score of 2 or greater is high risk for poor outcomes. Just know that Q-SOFA is for the inpatient team. I've had them ask me what's their Q-SOFA score. I'm like, I'm not worried about that. Here's your Sears, and I have a lactate of like 6, so I'm not really worried about it. And Sears has been proven to be superior. Again, does not confirm infection or sepsis. Just keep in mind if somebody's out running in 110-degree heat and broke their ankle and comes in, there's a good chance that they're going to be tachypnic, maybe they're dehydrated and they're hypotensive. They could be meeting that criteria, but not necessarily for Sears. I have this very cool slide here. Now, what I want you to realize is that Sears can run with a bunch of different things, mostly tied in as complementary with sepsis, mostly, because that's where those 2 circles cross, but just keep in mind that Sears can creep in with trauma, burns, and pancreatitis as well. Keep in mind those can be precursors, because pancreatitis is going to result in, all those 3 are potentially going to result in end organ damage, which puts us into the realm of Sears and then into the realm of potentially sepsis as well. So, cast a wide net when we're worried about this. What do we want to get right as soon as we can? Probably not the most favorite thing that your nursing staff or techs want to grab. Why? Because the lactate has to be put on ice. Has to be put on ice to go down. So lactate gives us an idea of mortality. It also gives us a good guide where we start that out at. And if we're giving fluids or giving antibiotics, we should see that lactate start decreasing. We know we're moving things in the right direction. If that lactate's not going the right way, we're not doing something right. We are not doing something right. So decreasing lactate, they're independent predictors. We want to make sure that that lactate is going down, not elevating. If it's elevating and hypotension is persisting despite pressors and fluids, we're not doing something right. We're not doing something right. Get after it. So again, patients do not clear their lactate, so they should drop at least 10% over the first few hours. So higher mortality, that's very concerning. So it can be elevated in several conditions. I talked about that. I see lactates elevated in people that have had seizures. I see lactates elevated in people that go on benders because it results with just generalized ischemia and poor oxygen delivery. Poor oxygen delivery. So if we get into that, we can potentially have two critical events that happen. So unfortunately, they can have a blunted inflammatory response later in sepsis, which is why we want to get on top of this as quickly as possible. So if they have that blunted inflammatory response, that's just another word for everybody. Remember the term apoptosis? We just have global cell death and end up having organ dysfunction. That's what I want you to take from that. So I want marked inflammatory response and then imbalance. Now we start dealing with this procoagulant anticoagulant function. So liver is not functioning properly, not producing the platelets that it needs to, not producing the white blood cells that it needs to. Then we start getting into the realm of GIC, starting with clot formations, that's micro and macro all over, which is going to severely affect what? The oxygen delivery as well. Everything's clotting up all over the place. These people do typically, if they hit this level, they're not going to be performing very well. There's going to be worsening of their condition. So sometimes they show up very quickly, but we need to look at those vital signs first off. So are they febrile or the hypertensive tachycardic? Those are a clue that there's something underlying that sepsis, and that's going to go along with your Hughes criteria. So what do we discuss? What kind of shock is sepsis? In the realm of, so it's a distributive shock. Distributive. So peripheral vasodilation, warm extremities where it's going to be trying to compensate initially, So it's good if we're seeing they're a little bit tachycardic, if they're hypotense, that means that their body's responding to that distributive shock. That's a good sign. All right. Widespread inflammation. Unfortunately, this is going to start affecting other organs, and where we're going to see that right there in the pulmonary. This is where these people start having ARDS. We're going to have a lot of edema that's happening in there. They're going to get refractory hypoxemia, non-compliant lungs, especially during mechanical ventilation, and then we're going to start seeing infiltrates. This is why we consider intubating these people early if they have altered mental status. So GCS 8 or less, then we need to be intubating these people because we're very concerned about ARDS. They're not going to be breathing properly to be helping out. The next organ that we're going to see is kidney function. Kidney function, obviously, with oliguria, where they're not going to be producing any urine, and it is not good at all. A significant vasodilation, we're starting to have kidney dysfunction. So we're going to see a significant amount of hypotension, dehydration, and then keep in mind you probably had to work that person up in the emergency department and got a CT scan looking for where that infection is going on. So we just gave them a good amount of contrast. Well, contrast is nephrotoxic. So now we just give the kidneys another hit for that, which is why I usually always rinse somebody's kidneys out. And then not every antibiotic is great for the kidneys either. The kidneys take care of excreting a lot of that, breaking it down. So be careful with aminoglycoside antibiotics. So, and then we just worry about that hypoperfusion that happens. If the hyperperfusion is happening in the body, the heart's not perfusing well, the brain's not perfusing well, we can assume the kidneys are not perfusing well as well. So we need to take a close look at those kidneys. What are our two labs that we look for to make sure the kidneys are functioning okay? Usually creatinine, GFR, BUN gives us a much better idea of that. Those can be other risk factors. And of course, liver, you can see that a lot. If we see a cholecystatic jaundice, That tells us that the liver is not functioning. It's caused stasis. It's not pushing that out. We need to make sure we're getting liver function tests, specifically looking at the outfloss. So if we see increases in the transaminases, that's AST, ALT, or bilirubin, we need to look for a biliary source of infection. Biliary source of infection. I'll get into that a little bit more with talking about that in block 3 as far as something called an acalculous cholecystitis. Anybody have an idea what that is? So that's an infected gallbladder, but they have no gallstones. Acalculous. It happens with really sick people, people that are septic have this problem. We get stasis in the body where organs stop functioning. That allows bacteria to grow and we get very sick. So just worried about those types of things. LFTs, if the liver's starting to take hits from that, we can see that is direct from endotoxin, cytokines, and the immune complex damage as the body unfortunately will start attacking itself. Most common GI manifestation of sepsis is yes, because the GI tract is not getting the blood that it needs, that peristalsis stops. It's not getting the oxygen and the glucose that it needs to function, then it's just going to stop. You're going to have an ileus. So that just complicates things because now we have GI infections, and then you get concerned if there's a contaminant. Upper GI bleed is rare in septic patients, but we do get worried about that because within 24 hours of the blood not getting properly to the GI tract, we're going to develop erosions, and that can cause a stress gastritis. So, and then stasis causes infection again. Sepsis includes, we can have neutropenia or neutrophilia as well as a thrombocytopenia. So this is a consequence usually of the DIC. So disseminated intravascular coagulation. This is fulminant DIC that's rare. It usually happens late in the phases when that person's like all their organs are shutting down, now they're going into DIC. That is kind of a last ditch effort. What they usually do, hemodialysis is what that patient's probably going to need as a last ditch effort. ECMO, hemodialysis, hopefully your hospital has that. Hopefully you don't have to see somebody that's in this bad condition, but it is very possible. So we deal with all those metabolic changes. That's why we want to get that lactate. Again, it gives us an idea that there's tissue hypoperfusion. Hyperglycemia, also a concern that we need to make sure we're checking that because that's an inflammatory response, stress response due to cortisol and adrenaline. So may cause a drop in hypoglycemia as well. Usually is reported, but it is very uncommon. So usually we're going to see a hyperkalemia. And if we think about this as an infection causing decay, now we've just complicated things. So we want to make sure that we're looking at all these types of things. You're going to be monitoring these folks. If you have somebody that's sick and sepsis, you're in the ICU. It's going to be nonstop labs. You're going to do rounds every morning talking about each specific organ and what you're going to do to fix that. It's pretty intense. So make sure you want to check to see if there's any underlying skin issues. So here's what we're going to see here. We see a cellulitis, erysipelas, which is just a superficial cellulitis, or fasciitis, which is very concerned. That is infection that's gone into the muscle. There are going to be lesions we need to look for. If there's any petechiae, pustules, cellulitis, gangrenosum, so we make sure that we're checking for any necrotic ulcers, especially immunocompromised folks. So microemboli, immune complex vasculitis, and toxic shock syndrome. So, concerning if it's necrotizing, what I want you to remember, if it's necrotizing, that's pain out of proportion on exam. P-O-P-O-E, pain out of proportion on exam. That's what's concerning for fasciitis. You touch it lightly, and that person screams at you. So I see that with compartment syndrome. I see that with a mesenteric ischemia. So those are the types of things you need to be concerned about for necrotizing. So you diagnose those people, please. I'm not going to get any deeper in the weeds with this too much with sepsis, but you need to be able to identify that serious criteria. That's what's going to tip you off right off the bat, what's going on. And then septic shock right down there. If that systolic blood pressure is still below 90 after initial fluid bolus. And I said, what's your initial fluid bolus? At least 20 milliliters per kilogram. At least that, and maybe a second one. And then if we need to We're going to look for a lactate. Anything above 4, anything above 2 is abnormal, but anything above 4 is evidence of inadequate organ perfusion. So both of those should tip you off. Systolic blood pressure after fluid bolus, below 90, lactate above 4, septic shock. And what I say, that's 50% of those people aren't going to make it out of the hospital. So this is a pretty serious type of thing. Pretty serious type of thing. Keep on your differential that there's other types of shock. There are other types of shock. You can have your cardiogenic, hypovolemic, anaphylactic, neurogenic, obstructive shocks versus your distributive shock, which is what sepsis is. Keep in mind that some of these can run together. Just because somebody has sepsis doesn't mean they can't have other things wrong with them at the same time. PEs, tamponades, endocrine disorders, thyroid storm. So, undifferentiated shock, we're looking at 4 out of 10 having sepsis, or 2 out of 5, however you want to break that down. So, just be worried about kiddos. I also worry about diabetics. They show up late to the course. They're compensating very well, and then they just tank really fast. They can usually have a good compensatory response with that until they burn through all their glucose and they've hit rock bottom. So just be aware of that. They do well until they can't. It's very quick. Here's our labs. I said pan culture. There it is right there. Urine. That means you're going to get a urine culture. Also get a UA. You also get blood cultures ×2. Again, if they have a fistula, we need to get a sample from that as well. I want to make sure that we're looking for those, looking for any occult bacterial infections. Some people are carriers of MRSA. Some people are carriers of other types of things. We get aware of that. CBC, we need to make sure that we're looking for that leukocytosis, electrolytes, including calcium and glucose, renal panel, lactic panel. We need a liver function panel. We want to have a baseline because if they start having end organ damage in their liver, we need to be able to notice that. So a lot of this stuff is just giving that baseline. So VBG, very useful. So it gives us an idea of how well they're perfusing. Type and screen if we're worried about, maybe we need to give this person give them any units later on. So if you're really worried about that, type and cross. And then if you're active bleeding or suspected DIC, let's go ahead and order your coag panel. Your fibrinogen needs to be separate and your D-dimer needs to be separate. But your coag panel will be picked up with your PT and your APTT. And we will take a break right there. We have 13 more slides on this. So I'll give you 10 minutes. If there's a pneumonia that we're not catching, now it should be a clinical decision, but the chest x-ray also gives us a good baseline. You get familiar with working in an ICU, they're going to take a chest x-ray every morning on a patient in ICU, especially if they're ventilated or have a central line. They need to be able to catch things early. If we're seeing early signs of pulmonary edema, if they're seeing early signs of pneumonia, they're going to go through that with a fine-tooth comb. Every morning they're going to get a chest x-ray or something in ICU. And then again, I put a lot of credence in abdominal plain films. Abdominal plain films be about good to show that a kid has constipation, FOS. That's about it. A lot more credence for CT scans and looking for the intra-abdominal sepsis. Ultrasound, very useful as far as the right upper quadrant to see if there's a biliary source. We need to take a look at the gallbladder. We're going to take a look at the common bile duct and some of the vasculature around there. But again, necrotizing soft tissue infections, low threshold for soft tissue CTs, or even ultrasounds, as in getting a formal by an ultrasound tech. And then again, worry about your head CT, and then an LP with potential meningitis. You're not really antibiotics putting those tests. You've heard that before. Again, we're going to make sure that we get 2 separate specimens for blood culture from different sites, not from the same site. And again, I told you if they have a porter official, you need to get an gram staining or culture from the other specific site. And then your ICU team, your inpatient team really appreciates a C-reactive protein and a procalcitonin. Here's our treatment ideas. What do we need to do? We need to recognize that. We're looking at vital signs, ABCs, our Sears criteria. And once we recognize that that's an issue, I have very low threshold to go ahead and pull the trigger. I'm like, I'm concerned that this is sepsis. I'm going to go ahead and start it. Plus, if I start IV antibiotics in the emergency department, do you think that inpatient team that I call up is likely going to tell me I should discharge my patient? When I started IV antibiotics, you're going to come down here to need the patient. That's how it's going to work. So it just lets them know that I need business. I started that. And if I'm about to and I want to just talk to them real quick, or I want to talk to infectious disease, I may request some ideas. There's just some slides in here that give you an idea based on where you think the source is, what antibiotics that you can reach for. Most of the time, it's going to be vancomycin. That just covers most everything, but not always. And then we need to reverse that hemodynamic compromise. That's with fluids initially, and then getting pressors on board. So, base that resuscitation, a lot of that just rolls all that up. Again, those 5 are all in tune with the 3 early. Keep in mind the word early there means we need to be thinking this quickly. We need to be on top of it quickly. Otherwise, these patients get worse. So, we want to get on top of that. Paying attention to resuscitation as far as preload, tissue perfusion, oxygen delivery. So fluids are going to help out with that preload. Tissue perfusion, do we need to put them on O2? Oxygen delivery, at some point there, do we need to get RBCs on board to help out with oxygen delivery? Because that's what's going to deliver oxygen to the tissues. So look at that, 2 to 5 liters of crystalloid in the first 6 hours if you're hanging on to them that long. I don't like hanging on to patients that long, but keep in mind that if you do want to start them on a vasopressor, that epinephrine is probably not going to be right there at the bedside. That's not usually something they keep in a crash cart. What we have to be familiar with is something temporizing. It's called push dose epi. Anybody heard of push dose epi? So you take a 10 cc syringe, squirt 1 cc out of that, fill that 1 c with crash cart epi, 1 cc, and then you can do push dose epi, giving anywhere from 1 to 2 mLs of that to produce the vasopressor effect that you need, causing inotropy as well as vasoconstriction. It's really going to help bring that blood pressure up. In the meantime, get better tissue perfusion. In the meantime, while that norepinephrine is coming in, being sent up from the pharmacy or over from the pharmacy or being pulled from the Pyxis. The point is, it's not in a crash cart. It's not going to be right there. So you might need to temporize with some push dose epi. This is also something that we use in our next lecture with anaphylaxis as well. So make sure initial bolus can go as high as 30. So 1 to 2 liters for a 70 kilogram adult is pretty normal. So if 2 liters aren't working, do you think 2 more are going to do the trick? Probably not, but let's go ahead and add that along with a vasopressor. Now we're going to see if it's going to work better. So what do we reach for normally? Right there. There's your best first choice. This is going to be potentially a pants question. You have person with sepsis. What's the very first vasopressor you're going to reach for? Why? You're going to reach for norepinephrine because it has dual alpha and beta adrenergic effects. So that causes vasoconstriction, what you need to help out with preload. And then it's going to have inotropy, which means it's going to make the heart beat harder and faster, which is what we need as well. So that's great. Epinephrine is down there as well as the bottom, but vasopressin is your second line. I'm not going to ask you a question about second line. You should know first line. Second line in phase 2. So first line, norepinephrine. So epinephrine, so that's usually push dose. Appears to be very safe. In a pinch, that's temporizing, so you're waiting on the norepinephrine to come in. We use that lactate clearance to give us an idea that we're moving in the right direction. So they came in, they're at 4. We start giving them fluids, vasopressor, oxygen, antibiotics, and then we're checking that lactate again. We want that to be continuing to decrease. That gives us an idea that now we're starting to get adequate tissue perfusion. We're getting them out of no man's land, no woman's land if you want. So lactate usually about 1 to 2 hours apart. Greater than 10% improved clinical outcomes. And then we want to give broad spectrum antibiotics. Got some slides coming up here in a minute. So surviving sepsis. Yeah. That was a great Freudian slip. Surviving sepsis campaign recommends giving antibiotics as soon as possible, ideally within an hour. Within 3 hours of triage. So we want to get this started earlier. This is again where people think that physicians, providers in the ER, Cavalier for starting this stuff. We want to get this going as quickly as possible. Ideally, within an hour of recognizing it, within 3 hours of triage. So make sure that we get their blood cultures, get an idea of an infectious source. So just keep in mind, it is not infection control, not confined to antimicrobial administration. What does that mean? Because you have people that were coming in with COVID, people that had C. diff, people that have droplet types of things. There's potential we need to isolate these people, put them in a negative pressure room. We get worried about that infection control at all. So COVID testing, droplet control, that's a big thing. You're not going to put somebody with COVID in the room with somebody that doesn't have COVID. Unless you just want to have both people have COVID. You don't want to do that. So here's just an example. I'm not going to test you on antibiotics, just have an idea. So there's something called the Stanford Guide. You can also look up anything on UpToDate and say, here's what I think the source is. They'll make recommendations on that. You can call up your infectious disease folks, but this just gives you examples of all the different medications that we can potentially reach for. So you see a lot of bank across the board here, a lot of bank. This is just to give you an idea. This is out of Tip Nally. Here's your empiric antibiotic infection is severe sepsis based on what you think the source is, what you think the source is. I don't care, just get started broad spectrum. I may pick up the phone and say, hey, I started banking Zosyn. Is there anything else that you think I should start? And let that inpatient team make a decision. Mostly what they're going to do is they're going to wait for the cultures to come back in 24 to 48 hours and see exactly what bug it grew out. Or they're going to keep doing studies trying to figure it out. But just to give you an idea, that is 1, 2, 3 slides just to give you an idea. So neutropenic fever is that last one. What do we think about neutropenic fever? I'm worried about somebody that's usually undergoing cancer treatment. So that's usually neutropenic fever. That's about a few things that I care about in the ER when I'm talking about hem-onc related things. So malignancy is the number one risk factor for pulmonary embolism. I worry about neutropenic fever, and then I worry about who your oncologist is because that can be my next phone call. That's it for me. Don't know what a Philadelphia chromosome is anymore. Seriously don't. But anyway, four there. Just give you an idea of what's going on. You even have one patient without a spleen. So ask about their surgical history. They've had their spleen out for whatever reason. You're going to reach for some different medications. They want those people to get ceftriaxone. Ceftriaxone for excluded patients. Again, just have an idea of the great reference to have. Questions on sepsis. Very, very serious thing that we don't mess around with. It's potential at some emergency departments. It's a third other code that they might have in their protocols. As in, I want you to call code sepsis. Okay? Some places have that, some places don't. All right, only a couple here.
Charlie.
So I didn't talk about dobutamine or dopamine, so we know that's out. Epinephrine is kind of at the bottom, similar, but we know that norepinephrine is our number one choice because it has the alpha and beta adrenergic effects. Affects vasoconstriction and inotrope. So I talked about those cornerstones, and those are 3 parts. Can you remove the source of infection? No.
Yeah.
So everyone agrees at A, right? So infection control. We need to reverse that hemodynamic compromise. So even maybe before, because they're in septic shock, even before we start antibiotics, we should be reaching fluid bolus and then reaching for vasopressor very early. So we need to start that tissue perfusion and then we take care of the infection control. Good deal. Some of you aren't going to like this next video. you're going to do it anyway. To be, it's just a matter of how allergic you are. So I've dealt with this quite a bit. I consider this more of a environmental emergency medicine, which means you're ready to rock and roll if somebody comes into the ER that's having an anaphylactic reaction to any number of things. We also worry about things like angioedema. What medication do we see that with? ACE inhibitors. So they get a little bit of cough, they get some angioedema. Those are a little bit more concerning because it deals with the face. So here's your objective. Whopping 24 slides, and we'll get through this today. But I want you to be aware of. So what do you think somebody dies from when they die from anaphylaxis? What is the cause?
Can't breathe.
A lot of people think it's airway obstruction. It's not.
What?
They actually, most people pass from shock. Now, airway obstruction, if you get stung in the mouth, or you have a food allergy because what's going to swell, areas that you don't want to swell, that's going to affect your airway. But the majority of people that die from anaphylaxis ultimately go into a distributive shock, and they go to cardiac arrest, believe it or not. So, and that's why that epinephrine is so important. That's why that epinephrine is so important. So epinephrine, first line for anaphylaxis. Carry these along. Plenty of times if somebody's allergic, they need to have one of these. I was giving them to one of my cousin's ex-husbands. He's a special forces guy stationed in Okinawa. He said the guy's having anaphylaxis. Little bit I know they were playing a game. He fell asleep in the office at work. You got an auto injector. And if I figured that out, I was like, no more. I'm not hooking you up for your games. Just be aware of that. So somewhere, I'm not going to test you on it, but you do need to know the doses. You need to know the doses for these. Obviously, kiddos being a little less, 0.01 mg per kid. I am 30 kilograms or less. So they do have EpiPen Juniors. They're green in nature. Then you have the adult dose. They started carrying these more in the emergency department because some people were accidentally reaching for crash cart epi. Completely different dosage. You can't do things that way. Not do things that way. But epinephrine, they say anywhere. There's a bunch of different literature on this, but about every 5 minutes, I would say, about every 5 minutes. 5 minutes. We do get concerned about biphasic reactions. So biphasic reaction, that means like 12 hours later, they'll just go into anaphylaxis. It's a very small percentage, 1% of folks, but they still have to let you know that's potential. So no high risk, observe for 1 hour, 6 hours if they're high risk if they're present. So there's your patient.
Bless you.
So 5 minutes ago, they get an EpiPen, they're going to come in. We probably need to start an IV, giving them some fluids to help out with the hypertension. And 5 minutes later, it's all right to give another dose of EpiPen. And everybody's familiar, anybody done wilderness EMT? Everybody knows there's more than one dose in EpiPen, right? You can look it up on YouTube. You can cut open that EpiPen and take the extra doses out if need be, if you're in a bad spot. This next slide I think is amazing. I want to take it out, but I can't just because I think it's funny. It's a serious allergic reaction. Okay? Now it has gone back and forth with what that term is. That's kind of why I leave it as anaphylaxis is now the proper terminology. There used to be anaphylactic and anaphylactoid were previous terms that were viewed to this IgE dependent and Ig independence, but anaphylaxis is now the term. Just want you to make sure that you're using the proper terminology. So immune response to this, anywhere from minor to severe manifestations. So we talked about maybe they just get a little bit of hives, maybe they end up going into full anaphylaxis. We worry about these things. We usually have lots of people identified. So foods, medication, insect stings. If they are getting allergen immunotherapy, that can be a provoking factor as well. Latex hypersensitivity. Some of you may find that out. A lot of the Coban that they brought downstairs when we do the IV lab, when they're putting the Coban on after the IVs, found a lot of people that actually had some minor latex hypersensitivities, but usually not that big an issue. But a lot of these, they identify no case. I think I probably had more cases where I've not been able to identify the offending agent or things, so that's just turned idiopathic. Pathophys on all this, all I want you to take away from this is that there are a lot of antigens that are involved with this, but it does have a lot to do with mast cells, basophils, and especially your IgE. Your IgE, that is probably going to be the immunoglobulin that affects us the most. I really do get a little bit more concerned, not so much with people with yeasting allergies, as long as they don't get stung in the face. And I worry about people with food allergies, particularly peanut and nut allergies. Peanut and nut allergies. Why? Because that's going to go in the throat. And I have had a ranger student on his way to Florida that thought he thought he could eat around the nuts in a bar and got into full anaphylaxis on the bus ride. Luckily, he had medics with EpiPens and we were able to take care of him. So it should have been an automatic drop in my opinion, or whatever. So, classic presentation: pruritus, just medical term for itching, cutaneous flushing, followed by urticaria. Urticaria just forming wheals, hives, if you will. Fullness of the throat, some of that has to do with kind of anxiety, sensation of chest tightness, shortness of breath, lightheadedness. Lump in the throat, very common, gives us an idea though that we might be having some underlying laryngeal edema, concerning that's going to be an airway issue, concerning this being an airway issue. When it really crosses in anaphylaxis for me is when it starts involving 3 or more different systems in the body. So if somebody starts saying they're having abdominal pain, cramping, nausea, vomiting, diarrhea, bronchospasm, so now we're not only affecting the skin, now we're affecting the abdomen, and now we're affecting the lungs. We're definitely in full-on anaphylaxis. So you need to be worried about that respiratory distress, decreased loss consciousness, and circulatory collapse. That's why I said shock. Shock is a more common thing. Now don't get me wrong, if you get stung in the mouth, if you're eating something that you're not supposed to because you're anaphylactic to it, then you need to be careful. So you gotta be careful with that. So anaphylaxis, so begin suddenly, often within 60 minutes of the exposure. Often 60 minutes of the exposure. The faster the onset of symptoms, the more severe it's going to be. So pucker factors should go up. Pucker factors should go up. That's starting to progress very quickly. Clinical diagnosis. Clinical diagnosis, no test that you're going to order right off the bat. We need to be able to identify that. You're going to do a physical exam, history of present illness, talking to your patient, hopefully they're talking back to you, and you're getting those things going. Most emergency room nurses know that if you say anaphylaxis, they're going to grab exactly what you need. EpiPen, usually famotidine, used to be Zantac back in the day. They got a black box for you. Apparently it and talcum powder and other things cause cancer. Whatever. So famotidine, Benadryl, and then sodium medrol is what we look at. I got a slide coming up here. So just be aware of that. And try and figure out what that exposure was. Do you remember being stung by a bee? Were you stung by a wasp? Did you identify it? Whatever, scorpion, whatever that might be. The last exam, or the last lecture, we'll go over that a little bit more. Make sure we're going through our ABCs. If they are having trouble breathing, having some anxiety, definitely a little bit of O2, whether non-rebreather is probably going to help that with. Probably going to help them out, calm them down a little bit. But just be aware these can mimic other things. Other things that it can mimic: vasovagal reactions, MIs. So severe asthma is probably a close one. You've got to be aware that epiglottitis, there's your hereditary angioedema, especially in little kiddos, not necessarily older folks, but especially in little kiddos, we worry about foreign body airway obstruction. So when I look for this, like mastocytosis. Where can you see mastocytosis in? That's increased red blood cells. What is that usually sequelae of? Any ideas? This was actually on my family. Significant alcohol consumption causes mastocytosis, surprisingly. Vocal cord dysfunction, and then you can have drug reactions associated with that as well. So, obviously, like everybody we have when they come in the emergency department, we're going to treat them all like the worst case scenarios. So ABCs in place. Getting our vitals, definitely getting a pulse ox. So get IV access because we're going to give most of those medications except for that epinephrine. Most of those medications are going to be given IV. Get them on oxygen. let's go ahead and get them on a cardiac monitor just to make sure. Epinephrine, but we also want to make sure we've taken care of that airway. In cases where somebody's decreasing, and these are usually kiddos that have come in because they have some type of food allergy and it's in their mouth, we need to look at securing that airway a little bit quicker. I'm going to tell you that right now. Probably like securing the airway at the same time you're giving them epi. So with the kiddos. So just be aware of that. Also, we do get concerned about decontamination. So if somebody's covered in beanies, I mean, you can't exactly jump in and take care of them. So there's potential for decon as well as that. So. In severe anaphylaxis, this is what I'm talking about. That person comes in, there's tripoding, they're in stridor. We need to look at taking that airway potentially before giving epinephrine. These are the cases that somebody's been stung in the back of the throat. These are the cases that they have a food allergy and they've eaten a lot of it. Why? Because if we lose that airway completely, and especially in a kiddo, good luck getting that back. Once that airway is completely occluded, we're having audible stridor, uvula edema, respiratory distress, hypoxia. We get complete obstruction secondary to that angioedema. We're not getting anything secured, and we don't cry kids under the age of 12. You're going to do something temporizing called jet insufflation. You're going to place a needle cry, and it's going to be temporizing until somebody can get down there and handle that. So, again, make sure that we're not exposing anybody else to that particular offending agent. So, how do we do that? Sometimes insect stings, most of them keep their stinger, but the honeybee doesn't. The honeybee leaves the stinger in. There's potential to make sure we get that stinger out and detach it from the insect. Again, anaphylaxis treated with epinephrine. Why exactly? Epinephrine has alpha-1 receptor activation, beta-1, and beta-2. So that's going to treat the hypotension, going to cause more inotropy in the heart. So, and it's going to limit further mediator release. So epinephrine is awesome. You make sure may need more than one EpiPen. I say every 5 minutes if they're not getting better, getting out of that spot, especially if you're in an austere environment. Especially if you're in an austere environment. So, administer epinephrine stat right there every 5 to 10 minutes. I say you're effective probably about every 5. That's going into the thigh is more effective than into the deltoid area. It goes into the thigh. Into the thigh. So trying to avoid that IT band. Doesn't feel too good when the needle goes into there. So intramuscular. Back in the day, it used to be subcutaneous. That is very suboptimal. This has to be intramuscular. It has to be intramuscular. So most are pretty good with a single dose. So be concerned if that have beta blocker on board, because that can also cause some opposition with the adrenergic stimulation. So if they have beta blockers and they have a whole bunch on board, glucagon is your reversal agent. So again, if they're refractory, there's potential that we can't start epinephrine infusion. We can do that push dose epi. So I explained that already. And then IV crystalloids going on with that because it's considered a distributed shot. Giving bolus to kiddos can be concurrent with the iron injection, concurrent with that. And here's your other therapies, your corticosteroids. That's usually solumedrol in the form of 125 milligrams. Your H1 plus your H2, so diphenhydramine, aka Benadryl, is your dose. I usually go high dose, 50. And then famotidine is your H2 blocker. What is famotidine also used for? H2 blocker? Purine, reflux. Probably one of the more common. So before people get on the meprazole, that can be used temporizing. And then vasopressors, reaching for that as well. And glucagon if we're worried about your patient taking beta blockers. And then always potentially, if they're still having kind of some respiratory distress, you can give them a bronchodilator. So albuterol. What do you got to warn people about albuterol?
Heart rate?
Yeah, heart rate's going to go up. And you're like, oh, I'm getting like flaring in my chest. That's okay. That's what beta blocker, that's what bronchodilators do. Disposition for these. So most of these people don't have to be admitted. Only rare, about 1 to 4%. But if that patient obviously requires some intubation, they're definitely coming in. So unstable patients should be admitted. They need to go to the ICU. So I'd say usually they say about 4 hours. 4 hours, if you're given that pen, is adequate time to observe the patient in the emergency department. Symptom-free, 1 or more 6 hours, these people can be discharged from home. I do just warn them about that biphasic reaction. Granted, it's only 1% of people, but just 12 hours later, that anaphylaxis can come raging back for unknown reason. Nobody has a good answer for that. Your disposition. People that are on beta blockers, consider keeping them in the emergency department a little longer. And then always consider these social factors, how far they live away, do they have good follow-up, and then elderly people that are asthmatics are usually going to be a higher concern or risk for that. So if they do have that, you're going to discharge them, make sure you discharge them with EpiPens. Usually comes in 2 per box, that helps out. Discharge them with some Benadryl, some Famotidine, and probably at least a little burst of steroid, some prednisone for 3 or 4 days. You're good to go. And then make sure they know how to call 911. And they know how to use that EpiPen as well. There's EpiPen trainers out there. Some of the boxes will come with an EpiPen trainer, so they know exactly how to do it. I have them just because I teach young Boy Scouts how to do that thing. But low suspicion for, again, that person comes in with severe respiratory distress, stridor, especially from a food allergy, and they're a kiddo, we need to really look at securing that airway very, very early. There's just a quick little run through on all the medications, specifically paying attention that we use that IM injection, and that is a 1 to 1,000 dosage. So you don't ever want to try to put in an auto injector in any way, shape, or form into an intravenous line. That is a crazy amount. It's really going to hurt somebody. Don't do that. But we'll give them a check on learning, and hopefully give you some time maybe to get one of your other instructors up here early. Sorry. Do you want me to keep going then?
Oh.
And then we'll just do like me, nobody's going to show up if you sit around. Especially in kiddos, where they're coming in really bad, we need to, before that epi, we really need to consider in the emergency department, so a patient coming by ambulance. Hopefully that EMS rig gave them some epi already, but this is a kiddo that we really need to consider right for that, especially when we're talking about food allergies. That is all in the oropharynx and esophagus, and it's just going to swell, and that airway's going to go so quickly. Pretty simple. We're reaching for epi right. I'm going to give that epi first. We're worried about all that swelling. We're also worried about airway tissues being stung in the face. They're all pretty similar. Like, we're going to get fluids because we just gave EpiPen 2 minutes before. I need to wait another 3 minutes. Let's get the fluids started and to give EpiPen if they're still hypotense after 3 minutes of fluids. Alright. I have no video for bites and stings. We'll go ahead and get this going because we kind of hit both of those with that watching poor Thomas Jib. There is some weird stuff on YouTube where there's this guy that has all these different types of bugs and animals that he basically like 10 minutes he lets them bite him or sting him just to see what it's like. It's very weird, but this is bites and stings and other things. We'll get into talk about these. These are reference material.
Experience pain.
Do you want a break, or you just want me to push through? Push through, there we go, zoom, zoom. Alright, it's only 37 slides, so we can go pretty quick. There's all your, this is mostly what we're talking about as far as the proper terminology is envenomation. And our first topic is medical term, are the more scientific term is Hymenoptera, and that's just a realm of bees and wasps. So it contains several components that cause that. That histamine response is what's going to cause vasodilation, the medulin, and when the phospholipase and hydrolysis. So these are protein enzymes that cause mostly systemic reactions to these stings or bites. So Hymenoptera share all these components. So if you're allergic to one, you're likely allergic to all of them. Likely allergic to all of them. So most common response, transient local reaction, just like a little bit of swelling, a little bit of pain, maybe some erythema, some little bit of hive action. So, but we do get worried about if there is a sting around the mouth and throat, and it's not fun. So bites around the eye can also be concerning as well. I would say if you have a bite or sting around the eye, we need to be concerned. There's potential that you need to get ophthalmology involved in the nursing department. Why look at those weird things? I don't get so worried about the lid swelling, but the atrophy of the iris lens abscess, there's potential for globe perforation. So that person I would definitely be getting intraocular pressure, probably getting a stain on it. Glaucoma, refractory changes. So we talk about lifeless eyesight. There's potential to get that person involved with that done specifically on the eye. But we're about anaphylaxis, usually within 15 minutes up until 6 hours, especially in our high risk folks. So this is anaphylaxis because it's involving multiple systems. You have nausea, vomiting, diarrhea, lightheadedness, syncope. You can have muscle spasms, but rarely seizures, and possible respiratory distress and cardiac arrest based on where they were stung. So you do not have to have urticaria or any bronchospasms present. So the more severe, again, like we talked about anaphylaxis, the sooner those reactions show up, the more severe they're likely going to be. So fatalities within the first hour are going to be due to airway obstruction because they were stung near the throat or mouth or from hypotension shock. General treatment, remove that stinger if possible, wash that site with soap and water, minimize the potential for infection. So application of a cold compress can help with pain and swelling. Those are very easy to happen in the emergency department. And then reaching potentially for oral analgesics. You don't need to reach for anything significant, any narcotics, but reaching for some Tylenol, NSAIDs, antihistamine can just reduce the discomfort. And then if there's swelling in that limb, a lot of people will report it kind of starts throbbing. They can elevate that above their heart and help out. Sometimes corticosteroids are used, usually mixed benefit, no clear understanding of that. Again, like all of our emergency medical cases, we need to look for ABCs first and foremost to make sure that we don't need to secure somebody's airway, but we need to fix that. So there's your IM epinephrine, same thing that we talked about with anaphylaxis, 1/1,000 concentration, and just remember kiddos. Like I said in the emergency department, because they've given crash cart epi and it's worth this because it's 1 to 10,000, doesn't really help out in trying to get that IM. We've started stocking everything now with EpiPen Juniors and regular EpiPens, so we don't get that mixed up. Getting that IM medication and then putting an IV in very early and reaching for all those medications. Again, every time that I've had an anaphylaxis in the emergency department, I just look at the nurse and say, we're treating anaphylaxis. They are literally grabbing everything out of the crash cart. So they grab the EpiPen, famotidine, Benadryl, and Solumetrol. So sending them home with steroids, antihistamines, and EpiPens. Don't not send them home. There's no reason for them to come back to the emergency department. If I have a choice between sending somebody home with medication so they can have it and not come back to the ED and wait another 6 hours, they're just going to be upset about that. So that's all your Hymenoptera. Pretty simple. This happens a lot. If you're out in the woods, people will have a tendency to find yellow jacket nests and all those types of things. And everybody knows how pheromones work, right? You piss them off, they're going to start marking you, and then they're going to start attacking you more. Once you've been marked, it's no point. Here is your ground of proof. I guarantee you will see this. Some of you, not everybody, because not everybody's going to take the exact pants. They're going to run a little deal and you're going to spit out 240 questions for you. If I know that this is the brown recluse, I would definitely be able to recognize what its Latin scientific name is as well. So usually found indoors, dark, dry areas to talk about. So if somebody gets stung by one of these, they're going to say they were in their basement, they were in the closet, and they're in a wood pile. So violin-shaped pattern on the cephalothorax of this. So it has these multiple enzymes, very similar to what causes necrosis in the body. Now look at where those are. Everybody's like, oh, that's only endemic to those areas. Well, I'm pretty sure brown recluse can like hop in a moving truck and get it somewhere up north to the back of your house. I'm just saying. So don't put all that much credence in this. I actually did have a guy bit by brown recluse at Ranger School, and he was good for about 24 hours. I used to have a picture. His entire hand swelled up, and he actually had to go to the operating room to get it all washed out. He got necrotic. Very nasty, very bad. I think it's the only brown recluse bite that I've ever seen. We'll get into that a little bit later to identify these. So, and what I was getting at here is he didn't come in until 24 hours after the bite because initially it's painless. Black widow, totally different story. So bite can and it can go even several days or weeks. So causes a local reaction, beginning with severe pain, usually hours after the bite. So and it's got erythema, pruritus, swelling. So it's going to get what's called by day 3 or 4 red, white, and blue. So erythema, blanching, ecchymosis, and that's kind of what's on the picture up there. So red, white, and blue lesion. You get very necrotic, can form shards, significant cosmetic defects, sometimes require skin grafting. So again, what I want you to take away, initially painless. Initially painless. It's going to happen in the same areas that the black widows wouldn't do that. So usually supportive measures, there can be antibiotics if that follows along. There's a bunch of these other medications. You're not going to see a lot of these unless you're going to be in an area that's very endemic with that, where you're going to have any of these medications. So dapsone has been shown to help out people with severe reactions. A surgical excision, ultimately, these would end up happening later on. But dapsone, some places, they don't have a lot of good research to support that. I don't think you're going to see that on your pants, and I'm not going to ask any questions on that. I need you to know that it's painless at first. Painless at first, and then that red, white, and blue lesion. Most of these people just need to be evaluated for serial wound evaluations to make sure that heals up and it doesn't get super necrotic or ulcerated. So they will usually kind of wait 2-3 weeks after that bite until they have clear margins before they go in and excise it. But if these patients have any continued symptoms, I don't send people home that have significant hypotension, hypertension, or sepsis. So just be aware of these folks. Here is the black widow. This is found worldwide. Obviously the orange-red hourglass shape that is on the abdomen there. You said female spiders are usually bigger than the males. So again, it's found in the same areas that we're going to find a brown recluse. So these are considered an aggressive spider. Not a necrotic type of thing. They have a potent venom called alotroxin, which has to do with their name. The problem is that this affects calcium channels. So predominantly the release of neurotransmitters, of acetylcholine and norepinephrine, which is why these are going to potentially cause spasms. Where do people report most of that? Usually in the abdomen, but they can also report that in the heart. Also in the heart, that acetylcholine release can cause neuromuscular manifestations. It counts for cardiovascular manifestations. So just being aware of that. Probably a little bit more concerning than the brown recluse. I want you to pay attention to here is a painful sight. Painful sight. And there we're right there. Abdominal wall muscle pain, cramping, well described. Hypertension and tachycardia as well because that norepinephrine release. So these people can also report other systemic symptoms is there. But then we also get very rarely reported, but because of that release, you can have atrial fibrillation, myocarditis, priapism. I think that's very interesting. Death. And this can be severe. Often treated, lasts for a day, but we want to get on top of that. There is potential to give this person IV calcium. may or may not be beneficial as if they're having those cardiovascular types of things. Mostly supportive measures. Severely painful, so low threshold rates for opioids. Anytime you're giving opioids, please give an antiemetic because they might be narcotic naive. Benzos you can reach for severe muscle spasms, and there are certain hospitals that have these a little bit more endemic, where they do have this lactobexus antivenin where they can get the benzo. That's for severe envenomations, but we also want to keep their pain control under. Again, we don't send those patients home if we don't have their pain under control, if they continue to be tachycardic, muscle spasms, severe pain. So antivenin has been proven to show. I don't know if I've ever been anywhere that carries antivenin. I usually don't see a lot of black widow bites, at least here in Texas. What I did see a lot of is this right here. I see a lot of scorpions. And this bark scorpion is definitely found in parts of Texas, you out to the hill country. Everybody take a black light, woods lamp, same thing. So these will all floor less. You can see them in the middle of the night, all floor less. Anyway, skin characteristics. Most of the guys at Fort Bliss thought it was funny if somebody fell asleep to take a scorpion and throw it down their pants. Weird stuff, but it can react on sodium channels, whereas more on calcium channels with the black widow. So I have not seen somebody that's been stung this amount. I've stepped on a whole nest of them once. Didn't feel great, but I didn't have a lot of symptoms like this. But there is potential for cardiovascular toxicity, resulting in tachycardia, hypertension, pulmonary movement, and cardiogenic shock. Has to do with the fact that it is reacting on the sodium channels, causing prolonged and excessive depolarization. Potential for nervous system toxicity as well, so oculomotor functions, so it's looking at somewhere acting on the face as far as the pharyngeal muscle control, tongue fasciculations, and then ultimately can affect the respiratory compromise with neuromuscular activity. Hypersalivation that affects the trigeminal, cranial, and glossopharyngeal nerves. So I've not ever had to actually treat these with anything. They're pretty much self-limited, but just keep in mind there's a list of potential things that you can take care of with this. Trying to guide. So mostly symptomatic treatment, as you can see right there. There is anti-venin out there in some places. Benzos if you're worried about any agitation, and then potential, obviously, any cholinergic effects. That's where that hypersalivation comes in. That's all the same way we treat nerve issues. So with atropine. So mild reactions, this is going to be probably like 95% of your patients that are going to be just fine. Make sure you take a look at their local reaction. Anytime that there's any type of envenomation in the skin, there's always a risk for secondary infection. I make sure to get it cleaned out while I'll tell them to keep tabs on it. So, but any systemic infections, nerve impairments, that happens from that, they will be. Everybody familiar with what this is? This is our snakes. We're really worried about snakes. Again, more endemic areas. This was a big deal in North Georgia. A lot of rattlesnakes, and these places are going to have more bites on average. So they said 6,000 bites, so not a huge amount, approximately 2,000 bites, venomous snakes. So this is usually summer months, because in the winter they're going to go and hide. So 25% mortality, but because we have more anti-venom out there, people are able to recognize it. We're able to transport people. Mortality is down to less than 25%. With only five deaths per year. So not a whole bunch of these, but here's the pathophysiology of this. We have our local tissue injury that occurs just from the bite and with the teeth, but then we have systemic vascular damage, hemolysis, fibrinolysis, and neuromuscular dysfunction. And that all has to do with the pathophysiology of the venom. So that venom quickly alters the blood vessel permeability, causing additional bleeding, loss of plasma and blood. It can cause hypovolemia. It can consume fibrinogen and platelets. So these are usually with our rattlesnake bites. So again, we can have some neuromuscular transmission, can cause some cranial nerve weaknesses as well. So about 1 in 4 of these are dry bites. About 1 in 4 of these are dry bites. So early symptoms, these people can have some generalized symptoms, nausea, vomiting, very ambiguous types of things, muscle fasciculations, can also change their vitals. They can be tachypneic, tachycardic, hypotense, altered level of consciousness. Usually becomes apparent within the first 15 to 30 minutes. Most of these people are going to tell whether or not they had a dry bite very early versus having some significant venom that's injected into their body. So, at the airway or muscle compartment can threaten life or limb. I don't know how you get stung near the airway, but I know some people like to get too close to Jake. And a lot of people get bit on the hand because they're trying to touch him and they just need to leave him alone. Don't be worried about that angioedema. Pretty significant ecchymosis is going to occur at the site, and that's the example right there on a picture bitten on the leg. So leakage of that blood vessel within minutes and hours. Can also form hemorrhagic blebs with this. So diagnosis of a snake bite, I need you to be able to pay attention to these types of things. What you need to be aware of. Yes, where to look for the fang bites, but do we know if it's dry or is it just one fang that got them? I'm not sure, but we need evidence of that tissue injury. So local injury, looking for swelling, pain, ecchymosis. We need to think about these hematologic abnormalities. So thrombocytopenia, is that going to be too much or too little? Too little, right? And that has to do with how the venom's reacting. If you have it too little, then it's going to have elevated time to clot. So you're going to have elevated prothrombin time. And then hypofibrinogenemia. You have to order a fibrinogen because it's going to break that down. And then you have the systemic effects as well. So hypotension, tachycardia is very concerning. You're not going to be usually hypertense. So absence of those following indicates a dry bite, which you need to know how those can manifest. Antivenin is the mainstay of therapy. Antivenin, so they've derived this usually from horses. They've immunized from snake venoms, and they're going to neutralize the venom molecules. So this is the one we're going to see the most. So developing progressive signs is the mean that we need to give that. So look at that progression right there. So worsening platelet counts, not elevated, prolonged coagulation times, decreased fibrinogen levels. We need to understand what those mean. Some of those go up, some of those go down. Obviously, coag times get longer, fibrinogen gets less, platelets get less. You need to know that if you're having any of those happening based on your labs that come in, you need to give somebody antivenin. If they get antivenin, they go to ICU. Automatic. They're not going to a ward. They're not going home. So how much are you looking at giving? 4 to 6 vials. Whew. Based upon where you are in the United States, I've seen vials as cheap as $2,500 a vial. At 4 to 6 vials, you do the math right there. That's well over 15 grand. That's just the first dose. I might need multiple doses. I've seen it go up to 5 grand in some other places. Usually a little bit cheaper down in Georgia because there's a lot of snake bites there. So just be aware of that. They might need that if they meet that progressive criteria. So there's potential for them to come in and get more, get initial doses, 2 vials at 6, 12, and 18 hours if the initial control is not achieved. So just be aware of that. 4 to 6 vials, that person's coming in the hospital for sure. So IV access, yes, we can do IO. Anything you can give IV, you can give IO. So we don't do it like rabies. We do not inject the antivenin anywhere near the site. It's just given in the IV. Okay, rabies, they're going to give shots directly into the bite site. It's not the same way that we treat this. Continue to observe systemic signs. Patients can have reactions to that, so keep that in mind. We want to make sure they have anaphylaxis during that. And then we're going to measure the limb circumference. So good use for a little bit of measuring tape every 30 minutes to see if that's going to swell. So about every 4 hours after the antivenin therapy. So person's worsens or fails to improve, there's potential to give them fluids as well as treating their hypotension. So FFP is a potential for any hematologic abnormalities. Fresh frozen plasma. Why? Because it replaces all the important factors that the venin takes away, which is fibrinogen, factor 5, factor 8, and factor 10. So observe the patients for 6 to 8 hours. Pain and swelling develops, and obviously life-threatening severe bites. Patients receiving antivenin go to the ICU. So low threshold for those. If they get antivenin, ICU. So, and then they need to be told if they are sent home, we're not concerned that it's a dry bite, and make sure that they can come back in because there can still be that damage done from the soft tissue of the bite. Anybody seen any of these around? I haven't here in San Antonio. So they're not very aggressive, but you still account for 20 to 25 bites a year. Yeah, you can remember that mnemonic. That's great. I kind of just leave all snakes alone, but just know that this is a neurotoxic component, no local injury. They have more like serrated teeth, more like fangs. So when they bite, more of a neurologic type of things. So these people that get this require 3 to 5 vials of antivenin to prevent. But they want to confirm that they've definitively been bitten because they don't want to cause any further effects with that. So there's potential for additional antivenin for these folks. But we want to make sure that that is clear identification of the snake bites, and then we need laboratory evidence that this is going on. So I think these people also go to the ICU as well. So antivenin therapy, there's some criteria that we need to give the antivenin right away, and that's really looking if there's any evidence of neurotoxic effects. What is that going to present as? We can see lid lacquer, ptosis, cranial nerve involvement, progressive muscle weakness, diaphragmatic involvement. That's very concerning because that person is having trouble breathing. And then we're going to get labs on these people, coagulopathies, rhabdo, renal failure, cardiac collapse, and then being unresponsive to antiemetics. So always administer the IV antivenin that's going to be given IV. Again, not injected into the bite site. Not seen any of these since I've been here in Texas, but I've seen plenty of that particular type of snake. Questions on bites and stings? We're down to A, D, and E because that's one of the things we talked about. But I said immediately painful. Immediately painful. And he's having some abdominal muscle cracking, so everybody's good with Black Widow, right? Black Widow. So it can't be A because I said thrombocytosis would be an increase in platelets. No, platelets are going to decrease, so we see thrombocytopenia. It breaks down fibrinogen, so fibrinogen is not going to be increased. Mild erythema and pain is kind of a normal reaction, whether that's a dry bite or whatever. And I said hypotension versus hypertension. So obviously abnormal mental status is going to trigger us to give antivenin. Like I said, know all those progressive criteria, because if you ever have to make a decision in the emergency department whether or not you're going to give antivenin, you have to understand those thrombocytopenia, increased coag times, and decreased fibrinogen, and then hypotension, tachycardia, altered mental status. You good on all that?
Cool.
I will save your review for tomorrow, if that's okay. We'll just do a rundown of all the subjects.